I will be presenting the results of a study on active screening for sexual and gender-based violence in MSF-supported health facilities in Nairobi, Eastlands. Sexual and gender-based violence, or SGBV, is defined as any act perpetrated against a person's will based on gender norms in unequal power relationships. A national survey in 2014 found that 12% of all women 15 to 49 years of age in Nairobi were survivors of sexual violence, and 35% of ever married women were survivors of intimate partner violence. Yet despite high physical and psychological burden, SGBV is rarely disclosed to service providers. Active screening aims to increase identification of survivors by proactively seeking them out through a standardized tool and process. Its usefulness and acceptability has been demonstrated in contexts where SGBV burden is high, but support services are also available. In Nairobi Eastlands, MSF supports a nurse-driven model of care for SGBV with a focus on sexual violence. And Epicentre was asked to support the OCP Matare project by assessing and documenting the introduction of active screening in 2 supported Ministry of Health facilities. The objectives were to evaluate the feasibility and acceptability of active screening and the uptake of related services, and of course to understand the survivors and health workers' perceptions of these. A mixed method sequential explanatory design was applied to monitor the pilot active screening activity for 4 months. The staggered start between the components allows for the qualitative component to provide explanations for emerging findings out of the quantitative one. Screening targeted adults and caretakers of children coming for routine services to Mama Lucy Kibaki Hospital and Makadara Health Facility, waiting areas of pediatric and adult outpatient departments, and maternal child health services. This flow chart shows the steps through active screening, SGBV services, and the study. Social worker interns screen people from waiting areas in private booths. All survivors using SGBV services were offered participation in the study, whether they had been screened or not. Participant information was collected from the nurse's case records and, when appropriate, asked about their experience with active screening. A subset of participants and healthcare workers were also offered participation in the qualitative interviews, which were recorded, transcribed, translated, and analyzed thematically. We applied the Assist screening tool, which has been used in similar settings after adapting it to the context and to the services offered. The process started by interviewers introducing SGBV concepts and the available support services, then asked 2 of the questions shown here, one focusing on physical violence by an intimate partner or another family member, and one about sexual violence. A similarly phrased set of questions was asked to caretakers of minors, focusing on physical violence by an adult or sexual violence on the child. Those with positive responses were offered to be brought to the SGBV nurse or social worker. Information and referrals were also offered to those screening negative but who wished more information, and of course health promotion material was given to all. There was a high uptake of screening, with 87% of the nearly 7,000 people approached in the waiting area accepting to be screened. 7% of them reported having experienced SGBV in the previous year. The majority of survivors were adult women, with over a third facing sexual violence and more than 2/3 physical gender-based violence. 40% of the 421 who screened positive were interested in speaking with a health professional about it and were thus referred. And 60% of these actually met with a dedicated health professional. Thus, 1 in 4 who screened positive benefited from the services. Of the 100 screened people who met with the SGBV nurse or social worker, 89 agreed to enroll in the study and were interviewed. As with screening, participants were mostly adult women, the perpetrator was almost always male, and for 3/4 an intimate partner. Violence included gender-based physical violence among 2/3 of survivors and sexual violence in over 1/3. Use of the first visit to SGBV nurse or social worker increased on average by 20%, with nearly all receiving 1 counseling session, 17% receiving medical services, 21% support through a police referral, and there were no recorded follow-up visits or with a psychologist or a second appointment with an SGBV nurse or social worker. The acceptability questionnaire addressed the helpfulness of the screening questions, the appropriateness of interviewers, if any questions were considered offensive, and if they felt a sense of privacy during the process. Participants largely found the screening process acceptable, with 94% responding positively to at least three of the four acceptability questions and 83% responding positively to all four. The qualitative findings showed that a good explanation of screening and services was crucial. These include proper delivery of background information on SGBV and the services provided, providing a good link to SGBV services after screening, and creating a sense of trust and confidentiality. This quote is from an interviewed survivor who explains the added value of screening. She said, "You may go to the hospital and not know who to talk to, so you just keep quiet and maybe nobody asks you." In addition to being feasible and acceptable, screening helped raise awareness that SGBV support services existed and that violence, including from an intimate partner, is not acceptable. Yet despite active screening being acceptable, there were persistent barriers to using services after screening. For instance, survivors discussed limited social support for care seeking and community norms that condoned or stigmatized seeking help, especially if it was an intimate partner violence case. Many survivors were unaware that intimate partner violence services existed, suggesting that screening also helped raise awareness. Some survivors felt that they could manage the event using their own coping mechanisms. Women were also concerned about the confidentiality of services, many of them fearing violent retribution or economic consequences from their partner if he found out. As this participant explains in the quote, that her husband warned her, "If I find out that you have told anyone, I will pour oil, lock you and the children in, and burn you to death." Screen survivors faced additional hurdles. They had originally come to the health center for a different appointment at the time of being screened, thus they had to queue twice, had limited time, were sometimes sick, or they were accompanying a sick child. We saw at times a gap between what survivors needed and what services were available to them. Health workers reported limited time, skills, and support to manage complex cases and intimate partner violence, as well as limited psychological services available to them. Survivors usually received a counseling session after screening, which they found helpful and supportive. However, some counseling messages normalized intimate partner violence. For example, this participant recounts being told by a health worker to consent to sexual violence from her husband and that it's normal to be beaten or forced to have sex inside your family. Survivors struggled to use legal services and police and faced additional challenges. They were often struggling economically, felt socially isolated, experienced mental health issues, and multiple and concurrent forms of violence. In conclusion, 7% of the waiting areas screened positive for SGBV. This was mostly for physical and sexual violence by an intimate partner, which reflects what we see in the community. Screening was found to be feasible, acceptable, and an efficient way to increase service uptake. However, due to known barriers, only 3 out of the 5 of those who screened who were identified and referred actually used the services. Active screening helped raise awareness of SGBV and related services among thousands of people, even those who screened negative. As applied, the active screening process and tool proved effective for detecting SGBV among adult women, but less so for men and children. If following this pilot phase, active screening is rolled out, there are several implementation factors which are important to consider, such as establishing trust and a sense of confidentiality with the survivor, providing a good background on SGBV and services, making a warm referral to services by accompanying the survivor, and reducing the waiting time. Operationally, this implies having trained health personnel with the time to carry out the activity and a conveniently located room or booth to offer privacy during the screening. These factors can also help address the loss between screening and service uptake. In its current form, the process would be best suited to target adult women survivors rather than men or children. And the study suggests that resources, tools, referrals, and the messaging towards patients could be better tailored to support survivors of intimate partner violence, and that gaps in counseling and mental health services could be addressed. We would like to thank the East Lyons community and everyone who made this study possible.